Once it's clear that non-surgical methods are failing, then the consideration is given to surgical treatment. Generally, we do not consider surgery unless a person is given at least 3, even 4 months of non-surgical treatment, and that's important as it's much less risky for you to heal these problems without surgery. You're exposed to less risk, and so maximizing your non-surgical efforts are critical before considering surgical treatment. Surgical treatment for hip impingement is focused at, first of all, repairing as best we can the damage to the labrum and cartilage of the hip. This can be done arthroscopically or open, or a combination of both. Generally, I do these surgeries arthroscopically. I first look inside the joint and assess the amount of cartilage damage. I repair what I can and smooth out what I cannot repair or what is too damaged to repair. I then look at the entire joint from the inside to assess for cartilage damage of the cartilage covering the bone, the hyaline cartilage. At this stage, there is not a lot we can do with significant hyaline cartilage damage in the hip particularly, but that is an area of focused research that I think will change over the next, hopefully over the next decade. Once I've assessed the entire joint and dealt with things inside the joint, I then focus on the hip socket, the rim of the hip socket, and the femoral neck to determine, as we've already determined likely prior to surgery, if these areas need to be shaped and changed to improve the mechanics of the joint and reduce the amount of further cartilage damage that occurs. This is the pincer cam type lesions that some people are aware of. Pincers generally overgrowth or prominence of the front of the hip socket. Malorientation of the socket as well can lead to this. Cam type impingement is generally the term we use for an abnormality at the head-neck junction of the femur that causes this bony impingement. And these areas are dealt with then to bring them as close as we can to their normal shape and improve the mechanics in that way. Associated things such as psoas tendon irritation, bursa as well can be assessed, and the abductor insertion as well can be checked at this time as well, once the main issues of impingement have been addressed if it's felt necessary. Complications of surgery: you're exposed to the risks of infection, blood clots with any surgery of the hip. The neurovascular structures around the hip are also at risk. We go very close to the nerve and vessels of the front and back of the hip, and these always need to be in the mind of us while operating to avoid any issues, but they are at risk. By doing bone work, we expose you to the risks as well of injury to the femoral neck as well as blood supply to the femoral head, and so removing as little bone as we can and avoiding the blood supply is critical during the surgery to avoid such problems as a femoral neck injury and blood supply problems to the femoral head afterwards. And then there are the general risks of anesthesia, particularly with patients who have cardiac or lung problems. These are risks. Generally, I do these surgeries with a spinal anesthetic. Occasionally, though, a general anesthetic with relaxation is needed to allow the tissue, muscles and structures around the hip to be as relaxed as possible during the surgery.